Hi guys, this is Dr. Kunal. On behalf of entire Miss family, I welcome you for this Pathology FMG exam recall question, the exam which was held on 18th of June 2021. Now before starting with this, I would like to thank all the students who have helped me in gathering these questions. I was overwhelmed by the amount of questions they were able to retain not only with pathology but with all the subjects. So I really thanks them that they have helped us in recalling all these questions. Secondly, this is a recall based session in which there might be some difference between the exact question which have been asked or the exact options, but what we have tried is to make the essence as close as possible to the exam questions. Now if you ask me how was the pathology part in the FMG exam on 18th of June, I would say the questions might not be from the topics in general pathology as such as from which we were expecting, but they were very easy questions, and I can vouch that people who have attended the classes, the chanting sessions, they must be able to make all the answers right. There were one or two questions which were a little tricky one, and we'll come on to that, but barring those questions, everything was very simple. So I really wish and hope that you have marked these questions correctly. So let's start with the session. The first question which came, a patient had a bee sting while going for lunch. He presented to the emergency room with tachycardia, hypotension and bronchospasm. Which mediator is responsible for his conditions? Now this is, by the look of it, the question is a question of type 1 hypersensitivity reaction. The patient is suffering from hypersensitivity type 1, and we have discussed in our classes that in type 1 hypersensitivity reactions, the antibody which is working is IgE antibody, but this IgE antibody is doing what? It is sensitizing the mast cells, and once there is an exposure happening again, then these mast cells, they secrete the granules, and what does the mast cell contains? The mast cell contains histamine granule, and once these histamine granules after the second exposure they are degranulated, then they cause vasodilation, increased vascular permeability and contraction of smooth muscles. So this question has been taught in your classes, and the correct answer for this question happens to be B, histamine. Now coming back to the second question, a man died on the operation table, heart biopsy was performed. On microscopic examination, apple green birefringence and salmon pink deposition were seen. What is the most probable cause of the death of the patient? Now we can totally understand this whenever we see this word apple green birefringence. So the first thing it draws us to is amyloidosis. So this is a question of amyloidosis, and we have discussed this again in the class that amyloidosis, one thing, the heart involvement is the most common cause of death in amyloidosis that we have written in the classes. The type of amyloid which we get in heart is ATTR, which we have written here. And secondly, I told you that the stain for amyloidosis is going to be Congo red. And in this Congo red, when you are seeing this on light microscopy, then you are getting a pink color which is exactly known as salmon pink color. And when you are taking this biopsy under a polarized microscope, you get apple green birefringence. So again, a straightforward question from the class notes. It's going to be, the answer is going to be cardiac amyloidosis. Then the third question, a tall young white male with gynecomastia, no axillary and pubic hairs. On examination, testicular atrophy is seen. What is the cause of these features? Now again, by looking at the options, you can see Klinefelter syndrome, Turner syndrome, Down syndrome and Noonan syndrome. Now once these features are not there in Downs, they are not there in Noonans, but then we can be confused between Klinefelters and Turners because they are the sex chromosomal disorders which are the most common cause of secondary hypogonadism in males and females. Now when we use the word male, the examiner used the word male already. Now in this male having testicular atrophy, that means it's a straightforward question of Klinefelter syndrome. And if you remember, we have discussed this like this in our classes, in which we have mentioned that in Klinefelter syndrome, this is the most common cause of male hypogonadism. Okay, it is written atrophies testes and gynecomastia. And again, we have seen these images in which you can see Tall male having breast development and atrophied testes. So there were two questions on exactly this. One we have discussed. The correct answer for this question happens to be Klinefelter syndrome. And the second question which came from this is this question: a patient presenting with gynecomastia, sparse axillary and pubic hairs, on examination found testicular atrophy, the most common genotype. Now same thing, but now they have asked genotype, and we have written, as I have shown you just now, that the most common genotype for Klinefelter syndrome happens to be 47XX-Y. So the correct answer for this question happens to be 47XX-Y. Moving on to the next question. The image shows reticulocytes stained by supravital stains. Which of the following statement is not true? Now they have given you the images, and they have given you very beautiful images of reticulocytes stained by supravital stains, and the options were that size of 30 microns, the reticulin stain in blue, they contains rRNA and does not have nucleus. Now this question again we have discussed very fondly and very clearly in the classes. I told you that RBC and reticulocytes, they are the two cells in RBC development lineage which does not have the nucleus. Above them, every cell of RBC development will have nucleus. So these are non-nucleated, number one. Then when we were discussing reticulocyte, I told you they are immature RBCs. That means they will be bigger than the RBC. What is the normal size of the RBC? 7 to 8 microns, right? So they will be bigger than the RBC, but then 30 microns? No. They are 8 to 10% bigger than the normal RBC. They're not, they're not so big than the RBC. They're present in the peripheral blood, they contain rRNA, and they are having supravital stains which are going to, stain them blue. So out of the options which I could collect from the students, I think the A option, size of 30 microns, is not a true option. Then moving ahead, treatment for the condition depicted below. Now very straightforward question once again, and you can see in the image, you can see the spooning of nail, right? This is called as koilonychia. And while teaching you in the classes, when I was teaching you iron deficiency anemia, we have written all these, if you remember. Iron deficiency anemia is the most common microcytic hypochromic anemia which we have in our country. And I told you that, MCV will be low, MCH will be low, even MCHC will be low in the patients of iron deficiency, severe iron deficiency, and RDW will be high, the red cell distribution width. And I told you that clinically these patients would have all the features of anemia, that is, fatigue, pallor, and so on, but they will also be presenting to you with pica and koilonychia. And we have made this diagram and showed this image also. So we can totally understand that if a koilonychia is seen, obviously the answer to this question would be iron supplementation, okay? Because this is a special feature for iron deficiency anemia. Now moving ahead, a patient came with complaints of pallor, fatigue, malaise. His lab findings shows decreased hemoglobin, decreased MCH, decreased MCV. What is the treatment for patient's condition? Now again, all the parameters or the RBC indices are low. Now when all the RBC indices are low, again the most common anemia which we have in our country in which all the indices are low is iron deficiency anemia, because iron deficiency anemia is the most common anemia in the developing countries. So obviously if it is coming from decreased hemoglobin, decreased MCH, decreased MCV, that means microcytic hypochromic, iron deficiency. So what you're going to give? You're going to give iron supplementation. So again a very straightforward question. Again we have discussed this. All these are low, they are in the iron deficiency. Moving on to the next question. A patient presenting to the clinic complaining of pallor, fatigue, weakness. Now the complete blood count indicates that the hemoglobin is decreased, but now the MCV is increased and even MCH is increased. So the volume is increasing, right? So if the volume is increasing, it becomes a macrocytic anemia. Macrocytic. What is the deficiency? What is the macrocytic anemia? We know. The macrocytic anemia which we have discussed in the classes, that is megaloblastic anemia. And out of the options given here, the correct answer obviously happens to be vitamin B12. So again a very simple question. I mean, they have asked these questions repeatedly in the exam. Earlier they used to ask, what is the type of macrocytic anemia? So vitamin B12 deficiency anemia. And once they have asked that, the MCV is more than 100 femtoliters, so what is the type of anemia it is? Again it is, the normal MCV happens to be 80 to 100 femtoliters. So if it is more than 100 femtoliters, that means the volume is increasing. That means the RBC is becoming big. So Again, vitamin B12 is the right answer for this question. Moving ahead, we have written this. You can see that I have told you that megaloblastic anemia can be due to vitamin B12 and vitamin B9, and this classical triad we have discussed, that there will be megalocytes or macrovalocytes, and with the volume will become more than 100 femtoliters and size will be more than 9 microns. So it's a big RBC you will find, and hypersegmented neutrophils and Howell-Jolly bodies. And I have told you that MCV and MCH is going to be increased, and this is one of the best screening tests we can do for megaloblastic anemias. Okay, so again a straightforward question they have asked in this, and I hope you all have marked it right, that it would be due to deficiency of vitamin B12 where you can have these kind of findings. Moving ahead to the next question. A 40-year-old man presented to the OPD with the complaints of generalized weakness, lethargy and shortness of breath. Investigations revealed methylmalonyl coenzyme A to be normal, but the homocysteine levels are increased. He is suffering from the deficiency of what? Which vitamin? Now we have discussed this again, that whenever they are talking about this methylmalonyl and homocysteine, that means the examiner is already telling you about the vitamin B12 and B9. The examiner is telling you about the megaloblastic anemia, and because in megaloblastic anemia both the vitamins are deficient, so as a doctor you need to know that what supplement you have to give to the patient. So you do what? You do a homocysteine coenzyme A levels. We have written very clearly in the classes, homocysteine coenzyme A levels will be increased in both, deficiency of both the vitamins. But methylmalonyl A will only increase in vitamin B12. So now if you see the question, methylmalonyl coenzyme A levels are normal. That means it's not B12. But homocysteine levels are increased. That means it is only B9. Okay, so folic acid deficiency would be seen. So the correct answer for this question will not be both B9 and B12. It will only be B9. Okay, it will only be B9. Again, the same image I have put here, that we have done this in the classes. I'm very happy to know that even in the chanting sessions we have done this. Even in the classes, we have done this thoroughly. So I really believe and really hope that whoever has done the classes with me, you people must have marked these questions correctly. Moving on to the next question, a patient is presented is planned to undergo a surgery. His lab findings reveals following values: shows hemoglobin 6.5 gram per deciliter, MCV increase that is more than 100 femtoliters. Next investigation should be. Now see. Again, they are giving you a patient who is anemic, and they are telling you that the volume is increased. Now, as soon as you understand the volume is increased, what is the normal volume? Normal volume of the RBC is 80 to 100 femtoliters, and now it is more than 100 femtoliters. That means the size of the RBC has increased. And once we know that the size of the RBC is increased, it's megaloblastic anemia. So obviously, what you can see in this, in iron levels there is no point, because MCV is increasing, so you need to check the vitamin B12 levels first, that whether the patient is suffering from megaloblastic anemia or not. So the correct answer for this question would be vitamin B12. Why we are not doing bone marrow examination? Very simple, guys. Bone marrow examination, I totally get it that bone marrow examination would be very, very, very significant, very specific, but then it's an invasive procedure. It's very painful for the patient. We do it, but then if we have other things to check first, which we can do, then we avoid the invasive procedures, and we here in the next investigation would be your vitamin B12 levels, because it's a non-invasive investigation. Moving on to the next question. A 60-year-old patient having cervical lymphadenopathy with increased blast count. His peripheral blood smear is given below. These are the cells which you are finding. What is the probable diagnosis for this patient? Now, as soon as you see these cells, you understand one thing, that they are big cells, okay? Compare the cells with the RBCs. They are very big cells having abundant nucleus and very scanty cytoplasm, okay? And the examiner has already told you that you are seeing blasts. So these are immature cells which you are getting. Now, when we talk about blast, looking at the question here, we can totally understand that, we have to first rule out the leukemias, right? So in leukemia, I told you that we have myeloblast and lymphoblast. We have made these diagrams, and I told you that if it would have been a myeloblast, it would have the vacuoles in the cytoplasm. It will have abundant cytoplasm, even the nucleoli. But if you see the image which you have got here, there is no nucleoli you are getting, guys. There is no nucleoli you are getting. So this is, and very scanty cytoplasm you are getting in these cells. So this is a case of a CLL. Okay, this is something which is having lymphoblast, and the options which we have, AML can't be the answer because it needs myeloblast over there and we don't have it. Then multiple myeloma will have plasma cells, lots of plasma cells, which we don't have it. And Hodgkin's lymphoma, I mean, you would get a Reed-Sternberg cell on the biopsy, right? With Hodgkin's lymphoma, these are not Reed-Sternberg cells. So they are lymphoblasts and they are going to cause, and even see the age, 60 years. So adult having lymphoblasts, obviously we know, we have discussed, it will be a clear-cut case of chronic lymphoid leukemia. Moving on to the next question. An African male presenting to the clinic with fatigue, fever, lymphadenopathy. The word African, I have discussed this in the class that if they are giving you a word African, and always look into the options for buckets. Shows starry sky appearance. We have revised it numerous times in the chanting sessions. We have revised numerous times in our classes, and even your TNDs had these questions. Then on genetic analysis, translocation 814. I don't know how many times we have revised, we have chanted this, translocation 814. 3 translocations I told you about Burkitt. This was the most common, and this is translocation 814. I mean, it's a direct, clear-cut question of Burkitt's lymphoma. See, we have discussed this, and I have told you here that Burkitt's lymphoma, it's most aggressive. These are the three translocations I told you. Even the mutation would be at c-MYC mutation, and you will have starry sky appearance. And this is what I have shown you with starry sky, that this is it like it looks. What are the stars? The stars are the macrophages. And what is the sky? The sky is composed of the tumor cells. Okay, stars are white, so macrophages, they have a little faded cytoplasm, so they look like stars, and sky is blue, and these tumor cells, they have abundant nuclear material, so they look blue, so that is why we call it as starry sky appearance. Okay, Burkitt lymphoma, straightforward. Then a 55-year-old male patient with increased ALP, increased calcium, increased PTH. Bone scans reveals osteolytic lesions. Smear of the patient shows the following cells. What is the diagnosis? Now again, the calcium is increasing, parathyroid hormone is increasing, even the ALP is increasing. And I told you, osteolytic lesions, these are some words, you just go to the options, and if you are finding any plasma cell disorder, and that too multiple myeloma over there, you just jump onto that. But if not, then this cell is a very characteristic cell. We have discussed in the classes that this is a type of a plasma cell which is called as Mot Cell, right? So this is a Mot Cell which we have. There is a, somebody told me that, they had given that the Mot cells are seen, and somebody said that only the picture was given. So I'm not pretty sure. But then if they have not even written that it's a Mot cell, you can very well understand by just looking at it. And Mot cells, they are the feature of multiple myeloma. So, these are the pictures I showed you in the classes. These are your normal plasma cells, eccentric nucleus. This is the cytoplasm and the nucleus. Then we have this Mot cell which came in the exam. We have these cells which are your Russell bodies, then your Dutcher bodies, and finally the flame cells which we have. All these cells, they are there in the multiple myeloma. 4 different types of plasma cells, modifications of plasma cells. We have discussed this again in the classes. So I hope that you have marked this question correctly, that the correct answer for this question would be A, multiple myeloma. Moving ahead, a female presenting with rash, fever, joint pain and chest pain. It is found to be having medium-sized vegetations on both sides of the wall. What is the probable cause? Now again, a straightforward question which have come from the classes. I'll not show you the options, I'll show you what we have discussed in the class. I showed you this, that in Libman-Sek endocarditis, when we were talking about vegetations, I told you 4 diseases, the NBTE, the rheumatic carditis, the infective endocarditis, and Libman-Sek endocarditis. And I told you, with Libman-Sek, I gave you this diagram, and I told you that on the both sides of the wall, we will have deposition in the cases of LSC, which is seen with systemic lupus erythematosus. This is, and we have even discussed that, with the infective endocarditis, there would be aortic valve involvement, whereas with all the 3 other diseases, that is your NBTE, your LSC and RHD, you will have mitral valve involvement, right? So again, a very straightforward question which have come in the exam, and you can very well see here, both the valves are involved in LSC. NBT, you have small varicose vegetations. Infective endocarditis, this is your non-sterile, very infective vegetation which is growing warty vegetation. And in RHD, there are small vegetations along the line of closure of the wall. This is what we have written in the classes. So again, I hope and I believe, I have a strong belief that you people must have done this question. Again, right, the answer to this question is going to be Libman-Sick endocarditis. Moving ahead, RBC cannot pass through the glomerulus because, now I remember that when I started with the renal pathology, we have discussed this in great detail. I've shown you these images and I told you that, the function of glomerulus is filtration, right? Now in filtration, there are three things which are helping glomerulus. One is the capillary wall containing the endothelial cells. Second is the basement membrane, and third happens to be your foot processes of podocytes. And we have discussed that if they are not injured, this RBC is bigger than the pores which we have for filtration. So these pores are very small and RBC is a big size. Even on the electron microscopy, you can see that RBC is such a big cell here, and how can it pass if the filtration membrane is absolutely fine, intact, right? So RBC can't pass through the glomerulus because it is big. Bound to transferrin or albumin or ceruloplasmin, that doesn't make sense. The correct answer for this question due to increased size. I hope this again you would have marked correctly. A male having occupational history of 30 years in cardboard industry, now presenting with hemoptysis, shortness of breath and chest pain. What is the cause? Now with this question, I mean, if this was the question, because there is some discrepancy in that, some people saying that cardboard industry was given. If the cardboard industry was given, then obviously, because it is using sugarcane, so bagasosis would be the answer for this. But somebody told me that, cardboard industry was not given, and there was occupational hazard like situation they have given, and they have said that the lungs are involved. So, I would, if that is the case, if that is not given, then asbestos will be the answer, because in the classes I told you that when we are talking about asbestosis, the most common cancer associated with asbestosis is lung cancer. So all these shortness of breath, hemoptysis and all these things you can see with asbestosis, and the most specific cancer which is associated with asbestosis is mesothelioma. So again I am repeating, if the question contained cardboard industry, then the answer to this question is bagasosis. But if that is not given, then the correct answer for this question would be asbestosis. Again, straight away from the classes. In Takayasu arthritis type 2, which of the following segment is most likely to be involved? Now, this is one question which we have not discussed as such. We have discussed Takayasu arthritis, but the types of Takayasu arthritis we have not discussed, because I have not seen it being asked. This is what we have discussed in the class, that Takayasu arthritis, it is it is also called as aortic arch syndrome, and the most common artery is subclavian artery. It is also called as pulseless disease, because you have difference in pulse in both the hands. So this we have discussed. Even I have shown you the gross and microscopy that what's going to happen in Takayasu arthritis. But because they have asked the type of Takayasu arthritis, so just for your reference, the type of Takayasu arthritis we have 5 types, okay? Now in type 1, it is the branches of the aortic arch, okay? Type 2A, which has been asked in the exam, is ascending aorta, aortic arch and its branches. Whereas if it is type 2B, then it is ascending aorta, aortic arch, branches plus the involvement of descending aorta too. Third is thoracic descending aorta, abdominal aorta. And type 4 is abdominal aorta and even the renal arteries, and type 5 is combined features of all the types, I mean type 2B and 4. So, generally we know that it's aortic arch syndrome, the arch of aorta and the subclavian artery is the most common. This is what we know always. But they have asked about type 2A, so it is ascending aorta, aortic arch and its branches. Okay? So, the correct answer for this question happens to be the ascending aorta and the aortic arch. Okay? Now, moving ahead. Surfactant is produced by, we know the answer, it is type 2 pneumocytes, and when we were discussing ARDS in the classes, this is the diagram we have made, and I specifically wrote this, that an alveoli is lined by type 1 and type 2 pneumocytes, and the function of type 1 pneumocyte is gaseous exchange, and type 2 pneumocytes has got 2 functions you can see here, surfactant production and repair. And in ARDS, both the types of pneumocytes are gone, and that is why we have this acute respiratory failure. right, distress. So the correct answer for this question happens to be type 2 pneumocytes. A middle-aged male who is being handling the pulses and grains for a very long period of time, he has developed hepatocellular carcinoma. So the toxin responsible. Now when we are discussing hepatocellular carcinoma, I told you that aflatoxin is something which is leading to development of hepatocellular carcinoma, even cirrhosis, the end stage liver disease. So as soon as you see aflatoxin in the option, I think there is nothing else to see in this, and they are talking about the toxins which can involve the pulses and the cereals. So the aflatoxin is the right answer for this question. Next, test used for finding number and type of immune cells. Now we were discussing this again and again. We do flow cytometry to find out the type and the number of immune cell, even the CD marker cells, which is there. Like when I was teaching you PNH, I showed you a diagram in which we, segregated that how much is CD55 and how much is CD59. So likewise, you can just relate it there that flow cytometry is the correct answer in this question when you need to know the number and type of immune cells. Gamma radiation before blood transfusion, again, it is to prevent the graft versus host disease. Again, we have discussed this in the class that whenever I hope you remember that graft rejection and graft versus host disease differentiation which we have done in the class, and I told you that you need to do, because in the graft versus host disease, who is more powerful? The graft is more powerful. So you are giving the gamma radiation so that there is decreased graft versus host disease chances in the patient. Okay. Then the next question, patient presented with thyroid swelling. On HPE, orphan Ani nuclei is seen. What is the answer? Very straightforward question. We have discussed this again in Miss Next Step that, and even in the chanting sessions also we have done this, that orphan Ani, whenever it comes, directly you have to jump to the papillary carcinoma thyroid. Okay, and you can see that we have discussed it here that in papillary carcinoma thyroid, see guys, it is the most common type of thyroid malignancy. Females are generally more commonly affected. Follicular cells are the place from where it is arising, and like medullary carcinoma of thyroid is arising from the parafollicular cells, but papillary is arising from the follicular cells only. Lymphatic route, okay, spread is there, and even the mutations, what we have written, very important, this RET and RAS. So BRAF, RAS and RET, these are the three mutations we have. Risk factors, exposure to the radiation, okay, and we have done this in chanting too, radiation exposure. And when we talk about the microscopic features of papillary carcinoma, these three features are very, very, very important. One, the nuclear grooves. When you see the tumor cells, if I zoom it for you, you can see this groove in the nucleus, this tumor cell, these grooves. So these grooves, nuclear grooves, they're giving nuclear grooves are seen. So this is your papillary carcinoma thyroid, which is, which shows us this. Pseudo inclusions you can see inside the tumor cells, you can see pseudo inclusions. Then your samoma bodies, again a very important, last time they asked you this question in regards to the brain tumor meningioma, the samoma bodies, which are the concentric calcifications, the calcium deposition, pathological calcium deposition, and this happens to be the orphan Ani nucleus, in which you can see that the nuclei they are empty. Okay, so this is orphan Ani nucleus, papillary carcinoma thyroid. So the correct answer for this question, straight away, papillary carcinoma thyroid. Moving on to the next question, a female presented with a hard breast lump. On microscopic examination of the biopsy tissue from the lump shows signet ring cells. Finding is suggestive of signet ring. It is intralobular carcinoma, breast. Okay, so when we are talking about signet ring or Indian file pattern, you can see this. We have discussed this again in the Miss Next tab. Invasive lobular carcinoma, it is due to decrease of E-cadherin, in which the tumor cells, E-cadherin is something which is combining the cells together. So when you do not have E-cadherin, these tumor cells, they will get separated. And when they get separated, they look like Indian file or single file pattern. Okay, and that is why, because the E-cadherin is low, that is why they can metastasize early and even can go to brain. And these are the images we have seen. This is the image which is showing us tumor cells arranged in line, like a file, like single file pattern. So this is your single line or Indian file pattern, and these are your beautiful cells, signet ring cells, in which you can very well see that this is a tumor cell, and the nucleus is pushed to one side. So it looks like a ring. So signet ring cells, they have given you the biopsy image also in the exam. Students have told me that both these images were given, and this is a straightforward question again coming from the theory part which we have done, and the answer for this question would be intralobular carcinoma. And moving on to the last question. A biopsy taken from a male patient who presented with scrotal enlargement shows the following microscopic findings as shown in the image given below. And laboratory finding shows normal AFP, elevated LDH. What is the diagnosis? Now guys, if you do not see this biopsy also, just by these tumor markers, if they are talking about a testicular malignancy, we can very well understand that it's a seminomatous malignancy. It is seminoma. Okay, and see, we have discussed this, that this is a picture of seminoma, and I have told you that in this you will have plaque positivity, beta HCG, and LDH is always high. And if you remember our chanting sessions, in the chanting sessions also with the tumor markers we did LDH is for seminoma. So elevated LDH, direct answer has to be the seminoma for this question. So again, a question which we have seen in the classes too, in the app, and we have discussed while doing our chanting sessions also. So again, you can mark this question correctly. So these were the questions which have come from pathology this time on 18th of June 2021, and I hope and I believe that with the combined efforts of everything, you must be able to solve most of the questions correctly in this, barring one question which we have not seen, that is type 2A Takayasu arthritis. Let me be very frank about it. And I wish you good luck for your upcoming results, and I have no doubt that you're going to come with flying colors. Now, for all the students who are seeing this video, I just want to say one thing, that we are proud of you, the way you have worked hard, the people who have given the exams, you always ask us that say a few words regarding talking and being motivated in life. I would say that the real motivation comes from within, and I always believed in this line, that whenever you feel low, you talk to yourself and you say that I know you are doing the best you can, and I believe in you, and you have to keep going. You have to start loving yourself. You have to have a self-belief. And this self-belief which you had for the last 6 months, which have made you so strong mentally and even knowledge-wise, believe me, see when the results will come out, you'll pass with flying colors. From entire team of MIST, I wish you good luck. Take care. Bye-bye.